for inviting us on this wonderful academic summit, NDAB Summit 2022. We are looking for really exciting academic feast covering multiple aspects of diabetes and endocrinology with recent advances for all of us. The first session where I am going to talk about sitagliptin, its effectiveness and safety, especially in elderly and special considerations. As we all know, we've been using sitagliptin more than a decade, and especially in elderly population, there are certain considerations. We'll have a very quick run through around the current scenario, our treatment goals for elderly, our challenges in meeting such challenges, and role of gliptins in elderly, especially in terms of its efficacy, its overall safety in terms of renal, cardiovascular, bone health and neurological issues, as well as adherence issues, and also the lower risk of hypoglycemia that this particular class of molecules are very well known of. Now, as you all know, you can call it a treatment success or advancement of therapy. The world is growing older. The population above the age of 65, around 8.5%, around 617 million in 2016, is expected to double to 17% by the year 2050. And the global population of the oldest old, that is above 80, very, very senior citizens, that is expected to get triple by the same time. And it is not surprising to note that non-communicable diseases are the main concern in such population. And naturally, type 2 diabetes remain the commonest chronic illness in such population. 1 out of 4 in that population is either having a diagnosed established type 2 diabetes mellitus or yet to get diagnosed undiagnosed type 2 diabetes mellitus. And cost of diabetes care, if we include both the components, the direct medical treatment cost as well as the loss of productivity, then it amounts an enormous quantum, an enormous challenge to our healthcare setup. In fact, up to 60%, almost up to 60% of our healthcare expenses are probably getting utilized across the globe for the care of these elderly diabetic subjects. Now, as you all know, there is a very steady, stable decline in beta cell function across the ages. Now, if we study in this patch clamp study, it was shown from age 20 to 70. If we look into insulin release and corresponding insulin sensitivity, there was a steady decline noted in progression of age. In terms of the first phase of insulin release, it was around 3 times faster decline, while for the second phase of insulin release, it was twice. It was more profound in patients having impaired glucose tolerance compared to the normal glucose profile. Now, even in such population where secretagogues are not expected to have their efficacy because of the declining beta cell mass, sitagliptin monotherapy in elderly have been established in certain therapies, multiple studies that they retain their effectiveness. And from a base level of around 7.8% A1C, they can contribute to a statistically significant A1C drop, a glucose drop corresponding by 20.4 milligram even within 3 days. And this effectiveness is age independent. There is a study in Japan, assist case study, where they have divided the population, around 1,000 patients were included, and they have divided the population into 3 different groups, less than 64 years, 65 to 74 years, and above 75 years. And it was shown quite consistently that the decline in A1C was around 0.62% or 0.6% or 0.53%, more or less pretty consistent, and there was no significant difference between the 3 subgroups. Now, you might be surprised to note that sitagliptin, in fact, is more effective in poor beta cell function, because in a person having depleted beta cell, you can see there is alpha predominance. So a drug which counteracts that glucagon axis is expected to be more efficacious So naturally, if we go by the HOMA-beta assessment and effectiveness, HbA1c reduction and HOMA-beta correspondence, we can see sitagliptin retains its effectiveness even more effective in such beta cell depleted subjects. Now, longer duration of diabetes is associated with a decline in EGFR. It's a kind of natural history, we can say. As the time progresses, from 30 to 40 years of age band, the process of decline begins, and it progresses around 0.5 to 1 ml per year. So naturally, once the diabetes duration is quite long enough, our choice of molecule is also restricted. The dose we use is restricted by the EGFR of the corresponding person. Now, sitagliptin in all three doses, be it 25 or 50 or 100 per day, been shown to be effective in elderly across the age band, across the EGFR categories. And you can see it could achieve the correspondingly proportionate A1C reduction in all three subgroups. And most importantly, over the follow-up period, there was no apparent change in baseline renal function. So probably we are having on one side a safe, durable glycemic control, also a preserved renal profile. If we go into this data where we had basic CKD patients having severe renal impairment patients and those who are having ESRD on hemodialysis, the choice of sitagliptin, the dose of sitagliptin, that was either 25 or 2550 milligram per day. But you can see the proportionate HbA1c reduction and safety efficacy maintained in all three subgroups. Now, sitagliptin versus sulfonylurea, if we compare them on another very critical aspect, there's a reduction of urinary albuminuria. Now, categorically in this study, we have seen those patients, around 1,000 patients were included having USCR more than 30. Sitagliptin was compared to sulfonylureas. It was shown significantly, statistically significant reduction, 15% reduction in urinary albumin creatinine ratio with a persuasive p-value of 0.001. And sitagliptin demonstrated increased USCR reduction, almost 20% larger USCR reduction compared to sulfonylureas. Now, TECO study, we all know, published in way back 2016, it showed unmatched safety profile of sitagliptin. Though the adverse effects, as one can expect, was more in elderly, more in CKD patients, but there was no evidence of adverse impact on the safety of endpoints in CKD patients, be it severe hypoglycemia, be it fracture, be it pancreatitis, be it malignancy. Over 4 years, EGFR was preserved and the adverse effects were within the acceptable norms of safety limits. Now, naturally, as we've been talking about hypoglycemia, that is one of the most dreadful, life-threatening complication that we want to get rid, especially in elderly. Why so? It is really very difficult to recognize in elderly because symptoms are often non-specific. It is quite easily misdiagnosed as vertigo or visual disturbance or suspected stroke. Often it's misinterpreted as a dementia-related symptoms or an agitation or a behavioral disorder. Its atypical presentation like confusion or delirium is often unnoted or missed to be picked up. And little warning sign or hypoglycemia awareness is a big issue. Then patients with dementia are unable to communicate appropriately, communicating their compromise in cognition. Now, naturally, with old age, malnutrition, presence of multiple comorbidities, chronic hepatic or renal dysfunction, presence of multiple acute illness, hospitalization, stroke or TIA or heart failure, or use of rapid-acting insulin, all these make a senior citizen more vulnerable, Polypharmacy, multiple medication drug interactions, blunted counter-regulatory responses, all these contribute. Lack of care facility, social isolation, component of depression and dementia make the whole thing pretty complicated. It was really interesting to observe in patients who were otherwise not achieving their glycemic target with sitagliptin metformin combination when they've been put on glargine. It was seen that those patients where sitagliptin was continued, they had lesser extent of hypoglycemia compared to those who were continued on metformin alone. But why so? Why this stunning thing? Now, probably we need to understand one thing, that sitagliptin or gliptins, they have a fascinating contribution on glucagon axis. If we look into this glucagon insulin axis, glucagon gets suppressed in hyperglycemic state in both healthy as well as diabetic patients. Now, hypoglycemic state, GIP induces an increase in glucagon concentration, but not GLP-1 infusions or saline infusion as shown in this study, thereby augmenting the endogenous glucose production. This was associated with a reduced need for exogenously added glucose to prevent hypoglycemia. This was a very pioneering study published in 2016, and these have shown probably the mechanistic basis how these sitagliptin or similar gliptins confer some protection against hypoglycemic incidences, especially in elderly or those having multiple comorbidities. Now, naturally, in an elderly, we are afraid of cardiovascular disease. Aging is quite synonymous with progression of cardiovascular disease or new onset of cardiovascular disease. With advancement of age, there are certain changes. On one side, there is increased fatigability, there is muscle weakness and wasting with lack of endurance capacity, limiting a person's physical activity, thereby lowering his or her energy expenditure. Naturally, there is concomitant rise in abdominal fat and obesity, increase in insulin resistance, contributing to the worsening of hypertension, atherosclerotic changes, dyslipidemia, worsening of glycemic control, and final common pathway of progression of cardiovascular disease. Now, old age is definitely associated with worse outcomes, but TICOs have categorically shown the comparison of event rates. In old age, we had significantly higher heart failure, hospitalization for heart failure or death. All-cause mortality was 2.5 times, while heart failure related admission was or death was twice. More incidence of malignancy, more incidence of severe hypoglycemia, and almost twice incidence of fracture. The primary and secondary composite, cardiovascular composites, were also significantly higher, around 1.7 to 1.8 times. Now, sitagliptin categorically shown, it has established its safety, that there was no worsening of outcome in such elderly population. You can see the confidence limit and use of sitagliptin in elderly was not associated with any further worsening of 3 or 4 point major adverse cardiovascular events, be it hospitalization for heart failure or death or all-cause mortality. Now, glycemic benefit of sitagliptin was adjusted in this study. So in actual, it is really something very robust and persuasive data. There is no increase in cardiovascular events in older patients who've been initiated on DPP-4 inhibitors. Compared to sulfonylureas, this is from the registry data of the Medicare, you can see gliptins were associated with much lower incidences of non-fatal MI, stroke, death, both in elderly patients and those with having established cardiovascular disease. Fracture is one more issue we are worried. It's a potentially explicable variables for the presence of fractures. Now, it was shown that patients with fracture, those who've been on agents, were essentially having low BMI and high osteoporosis and comorbidities. And probably that is something to very seriously consider. Now, fracture risk associated with common medication, if we have a look, thiazolidine, our favorite pioglitazone, which has got good stroke prevention data, but was associated either in meta-analysis of the study per se with almost 1.4541 times higher risk factors. Canagliflozin in particular had around 1.32 times higher risk factors. GLP-1 analogs were probably having a mixed data. On absolute value, they had something around 1.05, but meta-analysis on adjustment come to be quite safe, 1.0, while DPP-4 is having probably the safest profile, the hazard ratio having safest profile among the entire class. So if we look into the overall safety profile compared to the other hyped class of molecules, Glyptine remains one of the most durable, most effective, as well as safest class of molecule, even in high-risk population, having higher risk of fracture, higher risk of cardiovascular issues, higher risk of hypoglycemia. And naturally, they become our natural choice in elderly and special population. Now, if we look into the bone safety, it was shown that sitagliptin's effect on bone metabolism was predominantly through bone resorption rather than bone formation, as documented by the serum alkaline phosphatase and urinary deoxypyridinoline assessment. Sarcopenia, as we've been talking about, is one more issue, a chronic complication of type 2 diabetes in elderly. Relationship between age and appendicular skeletal muscles have been correlated, and skeletal muscle index across type 2 diabetes for each sex was noted in this study. And it was shown that not only sarcopenia, but also retinopathy had a very strong correlation. And prevalence of sarcopenia significantly increased along with the progression of diabetic retinopathy. It was noted that proliferative diabetic retinopathy was significantly associated with sarcopenia and poor muscle strength. Now, gliptins attenuate this decline of skeletal muscle, and it was shown that estimated change in skeletal muscle index in patients with DPP-4 inhibitor was significantly higher than patients without. It was quite persuasive, 0.04 or 0.03. Now, elderly diabetic having sarcopenia, what is the role of gliptine? It not only provides appropriate glycemic control, also reduces the inflammatory parameters and definitely a much better sarcopenic parameters, be fat-free mass or skeletal muscle mass or related incidence. Now, muscle strength, gait speed, all being compared with the sulfonylurea groups, and multivariate analysis confirmed that better sarcopenic parameters and preservation of lean body mass and strength and physical performance indices were noted with sitagliptin compared to the sulfonylurea. Last but not the least, if we look into the cognitive aspect, if we do a very simple mini mental score evaluation for assessment of cognitive decline and the dementia in older adults, it was shown whether we are looking for Alzheimer's or those without Alzheimer's, sitagliptin therapy was associated with a significant increase in mini mental state examination scores in either of the populations. Now, those having Alzheimer's receiving sitagliptin or insulin showed significantly higher MMSE compared to those who have been on metformin alone. Now, patients with Alzheimer's on sitagliptin showed significant improvement. So not only inflammatory, not only cardiovascular, not only renal or osteoprotective aspects, probably we are also having cognitive protective aspects. And with a very safer profile with very minimal adverse effects, the dropout or discontinuation of drug is really rare with gliptins. So naturally, there is much better treatment adherence than the conventional alternatives, be it sulfonylurea, be it TZDs or metformin alone. So to sum up, in elderly, especially elderly with type 2 diabetes, which is a very fast growing population with unique challenges, presence of multiple comorbidities do restrict our therapeutic choices. Often we fall short of our desirable efficacy or safety requirements. Gliptin's efficacy is age independent, a pretty rational choice to achieve glycemic targets, effective even in low EGFR or those on renal replacement therapy. Low risk of hypoglycemia is really a welcome thing in elderly who are at a much higher risk of hypoglycemia. Generally safe cardiovascular and overall tolerability profile, lower risk of fractures, sarcopenia, positive impact of cognitive decline in elderly makes these incretin-based therapies a better treatment option, as noted by better treatment adherence as well by our patients than other oral agents. With these words, I thank once again Lecton Synergy for inviting us on this platform for this academic fest. Looking forward to a fascinating 2.5 days of academic extravaganza. Thank you.
Thank you, Dr. Vishwas, for such a wonderful deliberation, taking us through the journey of elderly diabetes management. A few questions have come in. Can I pass it over to Dr. Ajay Vishwas?
Sure, please.
Yeah. There has been a question where people have asked that more and more surgical procedures are being offered to elderly subjects, as because life expectancy is going, you are having organ replacement, etc. And on the other hand, the time of in-hospital stay is becoming less and less day by day. So at times it becomes difficult, although textbook teaching says that if you are having a operative procedure, you need to be on insulin. So people are started on insulin and then they are sent home with discharge advice on insulin. It becomes very difficult to manage. Is there any role of sitagliptin in such patients by which we can minimize the insulin, etc.? Yeah, I think he's referring to the hospital study from sitagliptin. If you
essentially the scenario of using insulin as the only option in hospital scenario has grossly changed over time, and recent studies have categorically shown that sitagliptin, and even more studies are coming where we are having non-severe or non-acute situations. Their combination of even SGLT2 inhibitors along with DPP4 inhibitors are being used for short-term scenario, and not necessarily all admission requires insulinization. For example, someone requiring a surgery for cataract who's more or less controlled with oral agents probably will not require any replacement. Only where we are having difficulty in food intake or having other concomitant comorbidities which may be acute or fluctuating, probably those are the scenario where we need to still stick to insulin, and definitely use of SGLT2 inhibitors in such scenario where acute scenario can influence the higher incidence of glycemic ketoacidosis. One need to be very cautious. Otherwise, probably sitagliptin can cover to a much larger segment where we do not need to.
Thank you. I'll take a quick question before we move on to the next session. Our next delegate has asked that in how often do you find that your patient who has come to you at a tertiary care center or a secondary care center is on an inappropriate dose of sitagliptin? Is it very common?
Inappropriate dose is probably related to the education and awareness of the patient. I came across many people who just self adjust their dose of sitagliptin just because the sugar level
I
was
think
controlled.
the delegate is meaning that with regards to the EGFR,
Yeah. Both the versions we see. Normal EGFR taking half dose just because the last sugar report was appropriate, and the sitagliptin being a relatively more expensive gliptin, many people make it half. At the same time, I came across high dose of sitagliptin being inappropriately continued in terms of the lower EGFR range. So both scenario we have come across, and that's a quite common thing.
Thank you, Dr. Bishwas, for being there with us. In fact, thank you for organizing this conference. You are incidentally the organizing secretary of NIF. And
Definitely,
and I happen to be the secretary to the organizing
for all things that we have done. Thank you.
Thank you so much. And